Thank you, Chairman. Thank you. Again, high thrombus burden. High thrombus burden is a very important subject in our daily practice, but unfortunately we don't have evidence or solid data to what to do for those subset of patients who presented frequently and daily in our daily practice. I have a different scenario and different outcome. And from these scenarios, we want to get a consensus about what to do for those subset of patients. This is a young patient presented with chest pain of 3-hour duration. His ECG was extensive anterior MI, troponin positive with mild alveoli dysfunction. And this is his angio. There is a big thrombus in the proximal LID, which part of it passed distally and occluding the LID totally, and part of it passed to the diagonal, and the diagonal is totally occluded. What to do for this patient? As usual, I pass my wire, and the technician asked me, what should I give you? I told him, I don't know. Shall I give you aspiration catheter, balloon, or a stent? Really, I told him, I don't know what to do with this big thrombus. If I inflate it, it may explode, and it may embolize even to the left main stem. And the young patient is complaining from chest pain. So I told him, give me 3 seconds to think about what to do for this young patient. And after 3 seconds, I choose one of those. Should I go for pharmacoinvasive, aspirate, or go for stenting or ballooning? So I decided to give intracoronary thrombolytic. So after finishing the dose, the patient calmed down and he is not complaining from the chest pain further. And this is the angio after passing the wire and after giving the intracoronary thrombolytics. And the ECG change to accelerated idioventricular rhythm, which is a sign of revascularization. So how should I go again? Again, the technician asked me, what should I give you now? I told him, I don't know. How should I treat this young patient? He's stable now, EKG, the ST elevation, the current of injury is disappeared, and the patient is not complaining anymore. So what you want more from me, my technician? He told me, I want a complete revascularization. So how should I answer him? I don't know really. He asked me what the guideline says. I said to him, I don't know, because there is no guideline for this. So what's your guideline, dear? So I told him, to me, the less you do for this case, the more you get. So what should I give you, my doctor? I told him, give me nothing. Stay alone, I will pass and small holes in this thrombus and get the patient out from the cath lab, keep him on anticoagulation, and we will return him back after few days. This is the final result, and the patient not complaining anymore from the chest pain. So after 5 days, this is the RI system, it's completely normal. And this is the angio after 5 days. There is no thrombus in the distal LID. There is no any more thrombus in the diagonal. There is a remnant of the thrombus in the LID, but you have TIM3 flow, and the patient completely normal, and he is insisted on discharge because he is no more complaining from any chest pain or any dyspnea. And his ejection fraction at that time was 45, and after a few weeks, it became normal, near 60, without any stenting, without any intervention. So you have got a TIM3 flow with good myocardial flush, and you save the life of the patient. And put in your mind, not always the intervention is the solution. And I decided to go for wisdom rather than the courage in the dealing with this case in this young man. The second scenario. This is an elderly man with a lot of comorbidity. He's about 18, presented with acute inferior MI and bradycardia, and we struggle a lot for the excess. He has DVT, peripheral vascular disease, total radial, total right, common iliac, and hardly after 20 minutes we get the left femoral, and we go for angiography. The same story, but this patient, an old age. How could I give him thrombolytic? I couldn't. There is a risk. So my technician told me to start. Why we don't do the same thing? I told him this is contraindicated, near contraindicated for this old patient with this comorbidity to give thrombolytic. What about aspiration? I told him, go for aspiration. And this is after aspiration, and this is the result. And the chest pain disappeared, and the patient taken to the CCU, kept on heparin and dual antiplatelet, and he's very fine. And when we told him to go back to the cath lab, he told me, I will never get back again. You prick me a lot, and now I am very stable. So why I have to go in this age again for the cath lab? So we kept him on the treatment, and he continued to be in the good health for the last 9 months. This is the first part of the coin. So shall we go to the other part of the coin? This is a very young female. She is about 40 on contraceptive pills, presented with acute anterior STEMI. And she had a huge thrombus from the ostium to the middle LID and TIMI-1 flow. Admitted to the cath lab. At that time, the operator decided to go for adventure and dealing with this thrombus. Passed the wire. He started to balloon the thrombus. And first of all, the thrombus, the proximal part, embolized to the circumflex. Unfortunately, there is no wire in the circumflex. So the operator decided to go. He forgot anything about the LID, and he went to the circumflex because it was patent, and started to inflate. And you know the play of squash. When you hit the ball, it will return back again. So it is a big thrombus. Whenever you inflate it, it will go where? Distal to the side branch, or proximally to the left main stem, or circumflex. Now there is thrombus in the ostium of circumflex. It went to the first OM, occluded the OM, and definitely occluded the microvasculature. He started to open, and then it went to the circumflex and the second OM. So it's quite fair thrombus. It went to the distal circumflex and occluded the distal circumflex. So this thrombus distributed evenly for all the left system after intervention. So at that time, we occluded another branches, and this is near the final results. So we lost a lot. From this is the dark part of the coin. So from this, we conclude that the less you do, the more you get in the field of high thrombus. And be careful, don't stent. Even if the patient didn't develop no reflow, your stent 100% would be malopposed. Intervention with high thrombus burden equal to high complication rate. And enlarged thrombus burden, to me, try to achieve TIMI flow, whatever it is, and keep patient on intensive medical treatment. And this is the message from this case. The less you do, the more you get, and thanks a lot.